Thank you, Professor Ben. Now we have our next keynote lecture, Dr. McKenzie.
Yes, I'm John McKenzie from Melbourne, or Naarm, which is on the traditional lands of the Kulin Nation. And I'm here to invite Professor Sarah Coupland, who will update us on ocular melanomas, what's new in the WHO. Sarah is one of my diaspora of ophthalmic oncology friends, and she speaks with what we call an evolved Sydney accent. Her biography demonstrates the breadth of her clinical activity, where she's based in Liverpool. She heads the Super-Regional Ophthalmic Pathology Service there. This is a very pivotal part of an oncology service which runs parallel to her pathology service in Liverpool. A number of our Australian colleagues have done oncology fellowship training there, including Dan Mackay, being the most recent. He, being a dual fellowship holder in pathology, took a particular interest in and gained benefit from Sarah's expertise. Classification is vital to us as clinicians, as it enables us to stratify the condition and measure treatment outcomes. After the model of work, we're going to work fast, and I invite Professor Coupland to inform us about the WHO classification of hemolymphoid tumours as it relates to the eye. Thank you, Sarah. One last thing, sorry. This is an interactive session, so it should, on the app, a question and answer session should crop up. So if you want to ask questions at the end, if we have time, please use the app rather than waiting for a microphone. Thank you, Sarah.
Thank you very much, John, for the introduction. It's an absolute honour for me to be here and to speak to you about ocular lymphomas, an update on them, and how we, well, potentially the WHO, the new WHO lymphoma classification will influence how we diagnose and treat these patients. Here's the clicker. Sorry, I was just wondering how I was going to move the slides. Okay, so as you all know, essentially lymphomas can be divided into two main types, Hodgkin and non-Hodgkin lymphomas, and then further subdivision according to the cell of origin, whether they're B lymphocytes, T lymphocytes, or NK cells. And broadly, within the body, you can subdivide lymphomas according to where they occur, whether they occur within the lymph nodes or extranodally. And obviously, those lymphomas which occur in and around the eye are extranodal lymphomas. So when pathologists make the diagnosis of lymphoma, we use the consensus lymphoma classification, the WHO, which over time has been revised. But this incorporates clinical information and, as much as possible, please, histomorphology, immunophenotyping, and also the molecular genetics. As the last speaker indicated, revolutions are occurring in all areas of medicine, and including in molecular diagnostics. And so as a result of this, the new WHO lymphoma classification is not only including genetics, but also transcriptomics, proteomics, and epigenetics as well. But the main aim of the WHO tumor books, and there are a large series of them, is that each time they are revised, the revisions occur on the basis of evidence-based medicine, the literature, and to enable the diagnosis of these tumours worldwide, in whatever socioeconomic setting. And the current lead of the WHO tumour books is Ian Cree, who used to be an ophthalmic pathologist in Moorfields. And he took on this role about 5 years ago, and he essentially has modernized, I guess, the WHO, brought it all digitally, and such that all of the tumor volumes have a standard format and have particular subheadings, and the quality of the images have improved significantly, and all of them are online. He also fast-tracked the WHO eye tumour volume, which for some reason or another wasn't updated from the second version, and so he skipped the third version and went to the fourth volume. So this is how it used to look, the eye volume. A group of us got together in Lyon in 2018 when we all could come together at that time, and we put out the fourth volume of the WHO eye tumour volume at the end of 2018. And we're currently in the process of updating that, and it includes some of the pathologists here in the audience. So with the lymphoma classification, I'm involved in that as well. This incorporates the work of 380 authors from across the globe. And you can see here the number of editors and authors involved in producing this new revision. And since this has all taken place in 2021 and also the beginning of 2022, it's pretty been much online through numerous Zoom meetings at differing times of the day and night. And so this is the timeline. We started February 2021, and the final version has been signed off and is going to go to print and be released at the end of November. So there was two articles which were released back-to-back in Leukemia in July, and these are essentially a preview of what is coming out in the new WHO lymphoma classification. So what does this mean for the ocular lymphomas? Well, as you know, ocular lymphomas incorporate both ocular nexa lymphomas and the intraocular lymphomas. I won't be able to go into all of these today, and I'm going to concentrate mainly on the intraocular lymphomas. When we classify the intraocular lymphomas according to the WHO lymphoma classification, then the most common is a diffuse large cell B-cell lymphoma. In the ocular nexa, it's a low-grade B-cell lymphoma, the extranodal marginal zone B-cell lymphoma, or MALT lymphoma for short. And then, coincidentally, then the frequencies reverse, with the MALT lymphoma being the second most common in the eye, predominantly occurring in the choroid, and the diffuse large cell B-cell lymphoma in the ocular nexa. So, with the new WHO lymphoma classification, a new umbrella term has been created, and this is diffuse large cell B-cell lymphoma of an immune privileged site. And there are three lymphomas, and it's something that I'll come back to, which have been put in this umbrella classification. They are the vitreoretinal lymphomas, the testicular lymphomas, and CNS lymphomas. So, and this is just a summary of how the things have changed, that the diffuse large cell B-cell lymphoma, NOS, or not otherwise specified, has been refined and includes the vitreoretinal lymphomas in this immune privileged site category. So as you all know, and you're all clinicians, and you know this a lot better than I do, vitreoretinal lymphomas occur not only in immune-suppressed patients, but also in immunocompetent patients. There are a range of ocular and CNS manifestations. It can occur predominantly in the vitreous or combined vitreoretinal. It presents typically as a chronic uveitis, as a masquerade syndrome. And if there are any CNS features which can occur simultaneously, it is very much dependent on the site of the manifestation in the brain. Clinically, this is what you see. You have the opaque vitreous, you have infiltrates there, you have the leopard skin angiography, and you have these subretinal nodules on the OCT. Here's another example, care of Professor D'Amato, where you have the RPE atrophy and the subretinal atrophy, infiltrates. So when it comes to us as a pathologist diagnosing this, what I typically receive is an undiluted and a diluted vitrectomy sample. We work these up as cytospins, we stain them with MGG, perform then additional ones for the immunophenotyping, and this is an example of CD20, which is a B-cell marker, and they typically demonstrate medium to large B cells with a very high proliferation rate. So they're very aggressive B-cell lymphomas. Other people use flow cytometry to perform the immunophenotyping, and other techniques include the use of interleukin 10 and 6 and the ratio thereof, we typically reserve some of the sample to perform clonality analysis using IgH PCR or immunoglobulin heavy chain PCR. And approximately 70% of the vitreoretinal lymphomas also demonstrate an MYD88 mutation. And so what we also do is that if we have sufficient material, we do both the PCR and the MYD88 analysis. If we only have a small amount of DNA, then we do the MYD88 analysis only. Things that are in development is using aqueous taps and using droplet digital PCR to see if you can diagnose vitreoretinal lymphoma on the basis of the aqueous changes. Also, something that was published in California is using metagenomic deep sequencing. This is still very much in the realm of the research arena. Something that is definitely has been introduced is the development of next generation sequencing panels. So that we know in the meantime, it's something I'll go on to, that there are specific mutations which occur in vitreoretinal lymphoma. And as a result of that, then you can develop targeted tests to look at these particular genes to see if they're altered. And this was first developed by Canny and co-workers. I've been collaborating with a group in Tübingen in Germany where they've designed a next-generation sequencing panel for not only vitreoretinal lymphoma but also for CNS lymphoma. And another area is looking at the microRNAs, so the epigenetic changes. And this is still, again, very much in the research arena where you look at the constellation of particular microRNAs and compare them with those that occur in chronic uveitis. So larger specimens, you may be able to get subretinal aspirates or even chorioretinal biopsies. Obviously an advantage for pathologists, we can have more material to play with and we can understand the biologies of these tumours better. Just going back to this paper by Falco Fenn from Tübingen, this is really quite a landmark paper where he compared primary vitreoretinal lymphomas with secondary, so spread of systemic non-Hodgkin lymphomas to the eye, and also secondary spread from the CNS lymphomas into the eye. And first of all, he demonstrated, or his group demonstrated that, yes, the MYD88 mutation, one of the most frequent, CD79B mutation, and also new mutations in PIM1 and ETV6. He also demonstrated that more often not in the vitreoretinal lymphomas you had a loss of chromosome 9. And so this is helpful in making the diagnosis and differentiating from chronic uveitis. And this is just sort of a gene expression profile showing the differences between the primary and the secondary vitreoretinal lymphomas, which is very recently confirmed by a group from China. And again, showing that these were the main mutations which occurred in these tumors. So just turning back to this concept of the WHO in this umbrella term and placing the vitreoretinal lymphomas together with the CNS lymphomas and the testicular DLBL, there are advantages in doing this, in that comparing the similarities and differences between these tumors when they arise in these immune-privileged sites. And it also initiates collaborations between centres to fast-track research in these areas. So a lot of research has gone on in CNS, diffuse large cell B-cell lymphomas, less in vitreoretinal lymphomas just because they're rarer and we have limited material. But through these collaborations, I'm sure we'll have further advances in vitreoretinal lymphoma and the understanding of the disease. And this, just to show that one example of this is that Bjorn Chapuis, who is an oncologist in Berlin, he has done extensive work at vitreoretinal lymphomas and CNS lymphomas and suggested that the vitreoretinal lymphomas belong to a particular cluster, the so-called C5 cluster of diffuse large cell B-cell lymphomas. So turning now to perhaps something that interests you a touch more is the treatment of vitreoretinal lymphomas. And as you can see, there is a very long list of treatments according to whether the disease is limited within the eye whether it involves the brain or whether there even may be systemic spread, which occurs relatively rarely. However, most of these treatment options have been tried, but there, as you can see, there is no mainstay treatment for these patients. And if it's intraocular only, then I think most people either use methotrexate or rituximab. This is a very good paper which outlines a consortium's ideas and the strategies for the development of and application of treatments for patients with vitreoretinal lymphoma. Audits have been undertaken in single-center studies. However, I think something that really is a way going forward, a future development, as the previous speaker was emphasizing, is the development of registries across the globe and also the development of biorepositories so that we can improve the treatment of these patients and hopefully improve also their outcome. So this is just a summary of the features of vitreoretinal lymphoma in terms of the clinical, immunophenotypical, mutational, and what we understand in terms of the pathogenesis, and the recent proposal that they belong to this so-called C5 cluster. I'm going to move on very, very quickly because I know I don't have all that much time to just highlight the low-grade B-cell lymphomas that can occur in the eye, and these are significantly rarer. However, it is important to distinguish between the choroidal lymphomas and the vitreoretinal lymphomas because the patients with the choroidal lymphomas really have a very good prognosis. And so these used to be called uveal pseudotumors or even lymphoid hyperplasia, but it was again with a consortium that we were able to pull together cases and demonstrate that these were extranodal marginal zone B-cell lymphomas or MALT lymphomas. And these are some clinical pictures demonstrating that these lymphomas spread really within the uveal tract. They do not involve the retina. As you can see, the retinal vessels are intact. This is in a nucleated eye, and you can see this is an extensive choroidal lymphoma involving also the iris and extending posteriorly into the extraocular tissues. These lymphomas arise from the so-called marginal zone. They're small B cells. And when you look at the size of these B cells compared to erythrocytes, they're really the same size. This is another B cell marker, and that was just showing the Ki67 growth fraction. It's very low compared to that occurs in the vitreoretinal lymphomas. So essentially, to perhaps help understand these choroidal lymphomas, they're very similar to the ocular nexal MALT lymphomas. They have very similar morphology and also behavior. And they can occur, obviously, in the conjunctiva and also in the orbit, particularly in association with the lacrimal gland. And I just want to highlight this paper, which was recently published by the Bisgren Group and first author Lindsay McGrath, who summarized the presentation and also treatment of conjunctival lymphomas. And it was just highlights also in the new WHO book that MALT lymphomas have a range of locations, but interestingly, according to their location, they have differing genetic alterations. And you can't see the choroidal lymphomas listed up there. We don't really have sufficient number of examples to have done a sufficient amount of research to include them here. However, what is important with the ocular nexal lymphoma, or ocular nexal MALT lymphomas, they have a distinct chromosomal translocation and also genetic deletion. I think the jury is out when it comes to the association with chlamydia. So that's just a summary of the choroidal lymphomas. Also, if you're a clinician, always think that it could be a secondary manifestation of a systemic non-Hodgkin lymphoma in the eye, so a secondary uveal lymphoma, and these are examples from the Arano paper. These are rare examples, for example, of a CLL, a chronic lymphocytic leukemia, in the choroid. We had a very interesting case of an intravascular B-cell lymphoma, very aggressive B-cell lymphoma in this case. And then recently we had a case from Belfast where an elderly gentleman presented with a nasopharyngeal mass, but simultaneously had vitreal infiltrates, and this turned out to be an EBV positive T-NK cell lymphoma, exceptionally rare, and the patient was treated with intravitreal methotrexate and also with systemic chemotherapy, and on follow-up he's doing quite well. Also think of, particularly in immune-suppressed patients, of bugs such as toxoplasmosis with the extensive chorioretinitis, Candida, and obviously also in perhaps patients with transplants, Aspergillus, which can be very aggressive and destructive. So as a pathologist, I have just a little plea to all of you clinicians sending any samples with a suspicion of a lymphoma diagnosis. Please do not send it in glutaraldehyde. Glutaraldehyde is very strong fixative, and it doesn't allow for any immunophenotyping or any molecular genetics. If you are sending an intraocular biopsy, an iris biopsy, or chorioretinal biopsy, then it can come in buffered formalin, and we can usually do all of the conventional stains, immunostains, and also the molecular diagnostics on these samples, including analyses such as MYD88 analysis. If you're going to send a vitrectomy sample, then I would suggest to send it in a soft fixative, such as Cytolite or Hope fixation. I don't actually like formalin, because that means more often not you have to embed that sample into a paraffin wax and then do lots of sections, which is difficult if you have very few cells. So if you send it in a Cytolite, then we can create these cytospins and also do the flow cytometry. And obviously, if there is a suspicion also of microorganisms, then send a portion of that sample fresh to the laboratory so that it can be examined for your suspected bug. And last but not least, a plea to speak to your pathologist and let us know when you may be doing the vitrectomy, when you may be sending the sample, how you're sending the sample, and please don't send them on a Friday afternoon at 4 p.m. because they won't be found until Monday morning or even Tuesday. So please just keep that in mind. So just to summarize, I am a traditional pathologist. I do believe that morphology and immunophenotyping are the gold standard for making diagnoses of lymphomas in whatever body site. I think the WHO classification is continually revising and incorporating very important information which helps us understand the biology of the disease and design new clinical therapies. Molecular tests certainly do enable making unequivocal diagnoses, and some of these tests are really freely available, and the costs of them are decreasing so that they can be utilized in lower socioeconomic situations. Targeted therapies are developing as a result of our increasing knowledge about the vitreoretinal lymphomas. But I think, most importantly, that we need concerted international efforts in terms of the registry that was proposed, bioresources in terms of not only the tumor samples, but also blood samples, and also images. The previous speaker spoke about AI. I think we can do a lot with AI and the clinical images and also the histopathology to improve our understanding of these tumors, all with the ultimate aim of designing newer clinical trials and improving the therapy. So with that, I'd like to thank you very much for your attention. And finally, I'd like to remind you that you should book your hotels and your flights if you have a singing tendency to come along to Eurovision May 13th next year. Thank you very much.
Thank you, Sarah. As this is an update lecture, we do actually get to ask you questions. Unfortunately, in my work-life balance, my online questions system hasn't arisen. But so I'd ask you, if you wish to ask a question, come forward to the microphone at the front. I do, however, have a very keen student in Bill Glasson in the front row who has personally sent me a question. So perhaps we could ask him to...
Thank you, Sarah. I've been primed by Dr. McKenzie, of course. Two questions. first one is biopsies for ocular lymphoma are quite often small, and in our town we can rarely get a positive pathological diagnosis. Can you comment on the relative merits of flow cytometry, histology, and etc.? And second question is, low-grade ocular lymphoma can be treated with low-dose 4-grade radiotherapy. What happens in terms of the recurrence or disease progression? Are we seeing aggressive and progressive disease like clone selection with low-dose treatment with radiotherapy?
Two very loaded questions there. Perhaps with the first one. Yes, you're right. More often than not, the samples are very tiny. And in terms of what should be done, I think that, as I said, I think cytology is absolutely required. You have to know what you're examining when the sample arrives. We do immunocytology just because our lab doesn't have the experience of flow cytometry. But I do know that there are very experienced labs. The Sydney lab, for example, is very good at flow cytometry and working up these vitrectomy samples. And the vitrectomy, the vitreous is a different fluid, it's different to blood and things like that, so there has to be the pre-processing beforehand. And so labs that have that experience and know how to do it well, I think they're both very, very good methods in immunophenotyping the cells, the lymphocytes within the samples. I would always try and reserve a tiny portion of the sample for molecular testing, whether it's MID88 analysis or the IgH. Now, I know that it's very contentious with respect to the cytokines. In the UK, the ELISA test is not accredited for diagnosing a lymphoma, and an oncologist would not start chemotherapy on the basis of an ELISA test result. They would want to see the cytology, immunophenotyping, and a molecular test, and that additional information with respect to the cytokines is all well and good, but they wouldn't base the chemotherapy on that. So I know that differs across the globe. I know in France, for example, they do use that as a mainstay of making the diagnosis. So that was the first question. Second question.
Low-dose radiation.
So yes, the choroidal lymphomas, I think, are successfully treated with low-dose radiation. I think in terms of recurrence of tumours and the tumours coming back as more aggressive, for example, diffuse large or B-cell lymphoma occurs more often in the low-grade lymphomas in the ocular nexa. So if you have mold lymphomas in the ocular nexa which move around, left conjunctiva, right orbit, and then ultimately can spread systemically, there's a greater risk of the higher grade transformation. It's about 10 to 15% according to the literature. But that doesn't take into account the newer therapies that are being used for the treatment of the ocular nexal lymphomas now. But I think there is always that risk that, with perhaps a watch and wait protocol, that while that's happening, that there could be a higher grade malignant transformation of that low grade B-cell lymphoma and then a more rapid systemic spread. Does that answer your question?
Right, we have 4 minutes in our new world of work. We're moving fast. Are there any other questions out there? I think Sarah has told us all we ever need to know. So Sarah, just thank you for delivering the talk today.
Thank you very much.